hear you've also managed patients, and how do you assess, and where do you put imaging, where do you put PSA, quality of life, and even how do you remotely manage patients? Because you have a large draw where you are geographically.
Yeah, so I think our practice with seeing patients, especially we've looked at our own patient population at Vanderbilt, and we really do see patients traveling from quite a long distance, especially earlier, right after approval, they were really traveling quite far because regionally there just weren't a lot of centers. And so we do work really hard to try to minimize travel for patients. I think that more and more sites now are making radioligand therapy available, which is great for patients and less travel, but still a lot of patients are traveling quite a distance. And so when we do see patients, I usually encourage them to either have a PSMA scan already completed or get one as soon as possible. And a lot of times we're using outside imaging.
Right.
And so that does bring up one of the tricky
Absolutely, yes.
determining factors about qualifying for the PSMA-targeted therapies. The reads on the PSMA scans are highly variable by different nuclear med physicians and different radiologists. I think that in order to qualify for trials, patient had very strict and clear guidelines about who was likely to benefit from the radioligand therapy. And in real world settings, the reports are just not as clear in terms of SUV, disease heterogeneity or homogeneity. And so we do have, as you mentioned, a weekly tumor board with a medical oncologist, a nuclear medicine physician, and we go through each patient and really try to determine if they will qualify by vision criteria or therapy criteria, or, mimicking trials, because early on, I do think that there were many patients with no treatment options, and I think that we've gotten more refined in our selection of patients over time, because we did see that when patients do not meet the original trial criteria, they just don't do as well.
You're exactly right. And I think that using a combination of the trial criteria and assessment of even subgroup analysis and then real world evidence really lets us know how to manage. Because I remember early days, we had patients driving a few hours to Vanderbilt, which was one of our closest centers. I feel like I cut my teeth with y'all teaching and guiding and caring for those patients. And there were the patients who had no other options. And I appreciate the fact that your center and others have looked really at the patient series that they've had to see kind of like, truly hematologic toxicity plays a huge role. And a lot of the patients will have bone marrow compromise and toxicity. So that's a great point, which really leads us into, we have academic and we have community. And there are some community centers who have radioligand therapy either within their practice, within just their system. And there are centers such as mine in a community setting where I collaborate with Vanderbilt, and then recently with the ability of our local university, UAB, to have radioligand therapy, have been able to collaborate with nuclear medicine. And that's really, to me, where our multidisciplinary care of patients with prostate cancer has laid the groundwork for us to really collaborate closely with radiation oncology, nuclear medicine, urology, and as you alluded to, kind of having a regular radioligand therapy tumor board, if you will, because it is a lot of communication back and forth, which I think will get better over time with interoperability between EHRs. But we've had some instances where we're trying to get images to you, a lot of interesting little mishaps. But I think that as radioligand therapy is more present, academics generally first, and pervades into the community, we have the ability to collaborate, and we have colleagues who've laid the foreground on workflows. Just a really nice article for our colleagues in the audience, but Pedro Barada and their group, they have written a really nice kind of a skeleton, if you will, on how to proceed if you're just starting.
Can I just add to that? I think not only multidisciplinary, but also community with academics all coming together. The one barrier I still see is records communication.
Yes,
and
absolutely.
so I find that the easiest thing to do is a cell phone call. just
It is.
communicating. And it's nice because you actually get to know colleagues in the community, and it drives things like trial referrals. And it, it really does, I think, open up avenues for patients to get care at multiple centers, primarily staying at their home location for the long term, but coming for new cutting edge therapies and then returning home. And it's a very cool time to be in an evolving field like this. So.
You are right. Because at first we communicated as colleagues from my referral to you, and I think what's been really fun is being able to learn together and to develop friendships and relationships and professional networks and trial referral, exactly, to kind of push the treatment landscape forward.